If you're a psychiatry resident, you already know that diagnosing bipolar disorder can be one of the toughest challenges you face. So today, we're doing a deep dive into the essential assessment scales, the tools you'll be using every single day. Think of this as your practical, evidence-based guide to nailing the assessment.
I want to start with just one number, 8.74 years. Just let that sink in for a second. This isn't just some random statistic. It's a number that represents a massive clinical problem that we are all up against.
Because that's how long the average patient waits between first being told they have depression and finally getting the correct diagnosis of bipolar disorder. The consequences of that delay, they're devastating. We're talking about years of inappropriate treatment, a worsening course of illness, and just profound impairment in someone's life. This is exactly why getting a handle on these tools isn't just an academic exercise. It's absolutely critical for our patients.
So, how are we going to tackle this? We're going to walk through the entire process, like a clinician's journey. First, we'll unpack the assessment challenge itself. Then, we'll jump into screening tools. From there, we'll get into how to properly rate symptom severity. We'll also look beyond mood, at cognition and functioning. And finally, we'll pull it all together so you can build an integrated toolkit for your own practice. All right, so, Section 1. Let's dig into why this is so tricky in the first place. You know, bipolar disorder is just notoriously difficult to diagnose accurately right from the start. So, what makes it so tough? Well, for one, the symptoms look different in everyone. It's incredibly heterogeneous. The intensity and the length of episodes can be all over the map. Then you've got comorbidities, right? Things like substance use can seriously muddy the clinical picture. And maybe most importantly, a lot of the core symptoms are easily mistaken for something else, especially when a patient first comes to you in a depressive episode.
Okay, so with all those challenges, where do we even begin? That brings us to our first real step in the journey, effective screening. How do we even start to pick up on potential cases we might otherwise miss?
So, one of the first tools you'll probably reach for is the Mood Disorder Questionnaire, or the MDQ. It's exactly what it sounds like, a quick questionnaire the patient fills out themselves. It's basically a checklist, asking yes or no to 13 questions about a lifetime history of manic or hypomanic symptoms. It also asks if those symptoms happened around the same time and how much they messed with the person's life. It's designed to be super simple and fast for a busy clinic.
But here's where we have to be smart clinicians. The data from the landmark Hirschfeld study tells us everything we need to know. Look at the specificity. It's 0.97. That is incredibly high. Clinically, what that means is the MNDQ is fantastic at ruling the diagnosis out. A negative screen is pretty reassuring. But, and you have to hear this part, look at the sensitivity. It's a dismal 0.28. That means you're going to miss over 70% of true cases. It is not a tool for ruling the diagnosis in.
And this quote from the research really just says it all. The MDQ can help you rule out bipolar disorder, sure. But if you rely on it to find cases, you're going to miss a whole lot of patients who really need your help. The clinical takeaway here is that you have to know the limits of your tools. A positive screen means you absolutely need to dig deeper. But a negative screen doesn't mean the story's over.
Okay. So let's say the screen did raise your suspicion, or perhaps you're seeing a patient who's already been diagnosed. What's the next logical step? How do we go from, I think this might be bipolar, to systematically and objectively measuring just how severe their current mood state actually is?
And that brings us right to Section 3, the scales we use to rate symptom severity. This is where we start putting numbers to what we're observing, which is crucial for guiding treatment and, for tracking to see if what we're doing is actually working. Here's a quick look at the heavy hitters in our toolkit. For mania, the gold standard is the Young Mania Rating Scale, the YMRS. For depression, you've got the classic Hamilton or HAM-D and the more modern MADRS. And then there's this really interesting specialized tool, the Bipolar Depression Rating Scale, or BDRS. Let's break these down. So when you're assessing a depressive episode, you've basically got a choice. There's the HAM-D, which is the old school gold standard. To critique, though, is that it puts a lot of weight on physical symptoms. Sleep, appetite, the vegetative stuff. Then you have the MADRS. It was built specifically to be sensitive to change with treatment. It really hones in on the core psychological feelings of depression, the inner tension, the sadness, the bleak thoughts. Knowing the difference helps you pick the right tool for the right patient. Now for mania, the YMRS is your go-to, no question. It's just 11 items, you administer it as part of your interview,
and it's by far the most common scale used to measure manic symptoms. Here's a key clinical pearl. Its time frame is super short. It asks about symptoms only in the last 48 hours. This makes it incredibly useful for tracking rapid changes, like when you're in the hospital trying to get an acute episode under control.
And you really need to know about this one. The BDRS is so important because it was created with the knowledge that bipolar depression often just looks different from unipolar depression. It was specifically designed to catch those unique features we see so often. Things like mixed states, where you have manic energy with depressive mood, or that increased appetite and increased sleep. If you use a generic depression scale, you might miss these clues that are vital for diagnosis and treatment.
All right, a really thorough assessment has to go beyond just mood symptoms. We have to ask, how is this illness impacting a person's ability to think, to process information, and to just function in their daily life, even when they're euthemic or stable?
And just look at this data. It's pretty stark. Less than half of patients with bipolar disorder have what we'd call fully intact cognition. More than half have some level of impairment. About a third have selective deficits, so problems in specific areas like memory or executive function. And almost a quarter have global impairment, meaning it affects them across the board. This isn't a side issue. For many patients, it's a core, debilitating part of the illness.
So how do we measure this? Well, the International Society for Bipolar Disorders recommends a two-pronged approach. Think of it like getting both sides of the story. First, you use a subjective scale, like the COBRA, to understand the patient's own experience of their cognitive problems. What do they notice? Then, you use an objective test, like the SCIP, which actually measures their performance against population norms. You need both, because sometimes what a patient feels and what the tests show are two different things. Both are clinically important.
And that same idea applies to assessing daily functioning. So which tools are clinicians and researchers using the most? Well, check out this number, 40%. A big systematic review found that two specific tools, the GAF and the FAST, were used in about 40% of all studies on the topic. They are clearly the big players in this space.
And the FAST in particular is a fantastic, well-rounded tool. It's powerful because it doesn't just spit out one single score. It actually breaks down a person's life into these 6 crucial domains. It's looking at their independence, their ability to work, their cognitive function in daily life, how they handle money, the state of their relationships, and even if they can enjoy their free time. This gives you such a rich, real-world picture of the illness's true impact.
Okay, we have covered a ton of ground here. So, for our last section, let's pull all these pieces together. How do we build a practical, integrated toolkit that you can actually use?
So here it is, the bottom line. This is the big takeaway. The goal isn't to find the one single perfect scale. That doesn't exist. The goal is to conduct a truly holistic assessment. A great evaluation skillfully combines information from all of these different streams: screening, severity, cognition, and functioning. That complete, integrated view is what allows us to create treatment plans that are actually personalized and effective, because they treat the whole person, not just a number on a mood scale.
And yet, for all these powerful clinical tools, we're still missing that one thing, a definitive biological marker, a blood test for bipolar disorder. The lack of one has led some researchers to this really thought-provoking idea, which is summed up perfectly in this quote. What if we stop pouring all our energy into finding a biomarker for the illness itself, and instead shift our focus to predicting treatment response?
And that's the final, provocative thought I want to leave you with. In a field that doesn't have a simple lab test for its most complex illnesses, is this the future? Is the real power of these scales not just in diagnosing, but in helping us predict who will get better with which treatment? Answering that question is what's going to shape the future of our practice.